to just, we have just seen a couple of X-rays. We saw an MRI and a CT of the abdomen. We saw a few nuclear images of DOTA PET, FDG PET, and also we saw, I think, what else did we see? Yeah, I think that bone scan, because bone scan is something which we have to consciously train for exam, because we don't nowadays do bone scan in most of our patients, right? So now coming to specimen, so this was taken up for yesterday's discussion in our case sheet. I'm just bringing it back again because it's the easiest specimen to get. So 10 seconds. Somebody wants to identify what this is? So this is a specimen, orchidectomy specimen. So this is one area where anything and everything can be asked. So you have to be mentally prepared. Okay. So what happens is, let us say if this is the specimen of a, usually they start with, let us assume this was a 25-year-old male who came with a orchidectomy sample. So the question will be about seminoma, about non-seminomatous germ cell tumor. From there it goes to IgCCCG. You have to have some idea about S1, S2, S3 markers, good risk, intermediate, and poor risk. We should also be able to, can somebody tell me which are the poor risk features in seminoma? What if present in seminoma, you will say poor risk? 10 seconds. Usually our group of PGs are fastest on their fingers. So if it is not coming, it's a technical glitch, I think, for them also. They are not able to type.
No, it is coming in question and answer, Dr. Krishna.
Oh, it's coming in a different, not in the chat, is
Question
it?
and answer, it is coming. I think Aditya has answered S3. One more is missed, actually. Site is one more thing which is missed. Aditya.
Okay. So what we are seeing, it's coming under question and answer. So we are supposed to have it, that one open. Okay. Very novice, absolutely no idea about these technical things. Okay. So good. So there is no poor risk in seminoma. So that is the catch question. So seminoma, the worst thing can be an intermediate risk. So from there, some discussion can go on why high Ingwan orchidectomy, and then the lymphatic drainage of testis on the left, on the right. And from there, the discussion can go into testicular germ cell tumor. If you don't find a testicular germ cell tumor in the morning semi-long, this will be consciously kept for afternoon discussion. If the same tumor came in a 60-year-old male, what are the differential diagnoses? So starting from spermatocytic seminoma to NHL of the testis, you should be quite thorough. And in that, the questions will be targeted towards high-risk CNS IPI. What are the intrathecal drugs that you can give? So the examiner will consciously see if you are saying IT during the staging workup. So these are few small catch points. Please don't miss it during your presentation. Okay. And one second. So this is can somebody identify what this is? Can you identify the specimen? What is the specimen? So this is a, hepatectomy specimen. You can see the color, the consistency is very easy to say that it is HCC. So once again, if you have a patient with a liver, enlarged liver, that the discussion for the medical oncology exam can go in lines of HCC. But the questions normally are hovering around, how do you diagnose HCC? Do you need a biopsy? Who are the patients who don't need biopsy? So patients with high-risk cirrhotic conditions, especially HBV, HCV, or NFALD with typical cirrhosis and more than 1 centimeter nodule. If you have a multiphasic CT with the proper, the triple contrast washout phase, brilliant enhancement followed by washout, then you can go for a discussion with the radiologist. And if they say that if it is typical HCC, you don't need a biopsy. So from here, it will jump. Which are the other conditions in oncology where you don't need a biopsy to start treatment? So one is HCC. A child with hepatoblastoma lakhs, you find alpha fetoprotein. That is the other condition where you don't need a biopsy. Two markers other than LDH elevated and all typical findings of a germ cell tumor and the patient is sick, you can start treatment with etoposide cisplatin in a germ cell tumor without biopsy. In NHL, which is one condition where you don't go ahead and biopsy a lesion, but still you are able to find through other alternate methods, can be an extension question. Primary CNS lymphoma, HIV positive. If you are finding EBV positivity in the CSF, that's one more condition where you don't need a biopsy. So what are the conditions in medical oncology where you can start treatment without biopsy is something that can be asked. Very, very common spotter. This is a cystectomy specimen, ovarian cystectomy specimen. Somebody wants to put in the chat what is, it's easier to see in the chat because it pops up. But I think in the question answer, they are doing it. Okay. Very good. So it's a very typical, you find hair, you find keratinous material, cartilaginous material, it is teratoma. Good. So from here, the usual questions go in lines of benign cystic teratoma, the most common ovarian tumor in females. And in females, benign cystic teratoma, is it malignant or benign? You have a 30-year-old lady coming with this finding. And the histopathology is mature teratoma. Malignant or benign? Chemo yes, chemo no. Udiptiya says benign. Dr. Tulasi says malignant. Anybody else? Some still seem to be confused. Adult patient, benign cystic teratoma, female, young, benign cystic teratoma. It's all benign. No chemotherapy. Now, suppose if this was a testicular specimen, 22-year-old male, completely high angle oscectomy done, mature cystic teratoma. Benign, malignant. Chemo yes, chemo no. 10 seconds. Afroz says it's malignant. Others? Hemalata, Ketan? Dr. Hani? 22-year-old male? Tulasi says malignant. Dr. Ketan says no chemo. So always remember, pre-pubertal cystic teratoma or pre-pubertal mature teratoma in the male is usually taken as even keep under follow-up. Post-pubertal, you have to take as malignant and treat in lines of germ cell tumor. Many times they receive one cycle BEP if it is stage 1. Obviously, if they have metastasis, you are going to proceed. Very, very typical specimen, which is there in most of the tumor banks. What is this? 10 seconds. Very good. FAP. So what are the two types of FAP clinically that is going to make a difference in your clinical practice? So you can have either an FAP or you can have an attenuated FAP. So that can come in for some discussion. So you have to know what is FAP, what is the gene involved in FAP, what is the gene involved in attenuated FAP, some clinical and screening differences between FAP and attenuated FAP. Just know it. For your benefit, I've just put a tabular column here. The classical FAP usually have hundreds of polyps studded, maybe even thousands. And whereas the attenuated FAP is less than 100, usually in only 40, 20, 30 polyps may be there. And the adult onset is likely to be attenuated FAP, whereas the classical FAP, all symptoms come in very early. And the CRC risk is slightly lower in attenuated FAP. And you have the APC gene mutation almost is located at the same end. You may also have a MUTYH, which is a one more mutation variant, which can be there in attenuated FAP. And you can still do surveillance colonoscopy without colectomy in attenuated FAP if the number of polyps are very less or you don't have high-grade dysplasia or any other major issues. But you have to do. So these are some of the points for screening. I'm just holding the screen for about 10 seconds. It is not only colorectal screening. What are the other extra colonic malignancies in FAP will be the question. All of you know FAP, all of you know colorectal cancer, but you should know what are the non-colorectal malignancies. Thyroid is there, desmoid tumor is there. If it's a child, hepatoblastoma can be there because of the APC gene. You may also have upper GI tumors like duodenal polyps going in for duodenal adenocarcinoma in FAP. Therefore, it is not enough if you just do colonic screening, which starts at the age of 12 and culminates by about 24 or 25, because you are preferably going to do a colectomy by 25 years. You are not going to allow the FAP child to just live like that. So you allow him to grow and by 25 years. But if the patient has any high risk invasive adenocarcinoma that is coming up much early and the polyps seem to be becoming very dysplastic and the screening interval is coming to 6 months, you know the biology is becoming more aggressive, you may have to do a total colectomy even at a younger age. Otherwise, it is usually done around 25 years. So these are few things which are usually focused when you have a FAP specimen, and they will go ahead. So this is about prophylactic surgery. There are three types of prophylactic surgery where you can do only total colectomy. You can do ileorectal anastomosis, or you may have to do a idioanal, or even up to maximum anus if you want to remove and then only leave a permanent ileostomy. It all depends on how many polyps are there and how bad is the dysplasia. If it is worse, you go and do a more radical surgery. If it is not that much, you can still do a ileorectal anastomosis. But you should remember that even in the rectum, you can have FAP leading to CA rectum. So FAP is more of a theoretical discussion, and that will come, if at all, only during the afternoon session where you have a polyposis sample. I think Vinayak will step in. Vinayak.
Good morning,
So
student.
those are the ones. And Vinayak, I would just give 2 minutes. We will give a break. I would like to take your input from what the radiology and other things we have done. Anything else you would like to tell our students?
I think yeah, it was good actually. They would have more of theory material along with these questions. Usually, there is no set pattern of questions to be asked. It is just a trigger for to ask questions. For example, that Wilms tumor can go to RCC. It can go to familial cancers. Be ready with the image correctly so that you should not make any mistake in the images. I will cover few of the other investigations, but usually you should get the image right. And once you're done with theory, you have to study systematically all the topics which should come. Uh, the So shall I start, Dr. Krishna? Can I share the
Yeah,
screen
yeah,
now?
yeah.
You
I
can.
think I will stop sharing. You can. They actually this Vinayak, what I amended the slide. Do you have the slide new deck which I sent you in the morning? Yeah.
Yes.
So I will stop sharing. You can take from your side, and I will just be logged in.
No, you be there, sir.
Yeah, yeah.
Just from the team, you can see the slides.
Yes, sir, we can see the
Yeah.
slides, sir.
Clearly seen.
So students, usually practical exam, I think we will just you'll have one long case, two short case. I'm assuming most of them are DNB students. So your marks for those three cases will decide most of your scoring. So you will be you will be prepared well. What I've seen for a long time is long case and short case students are well prepared, and usually except for people who are anxious a little bit, otherwise most of people do well. Spotters and ward rounds, sometimes the answers are so not prepared that you answer without any forethought. So you have to give 1 or 2 days before your practical exam to do thoroughly revision of all the slides. This slides will be shared, so at least you should go through it off. Okay, so just can I see the same screen question answers? Yes. So the clinical cases. Any students want to take this thing? What is the patient is
Please
suffering from?
drop in the chat box like before. Please
Yeah.
make it interactive with Professor Maka.
Yes. It's a chemotherapy-induced alopecia. So what drug you think it is? So what are two kinds of alopecia? Okay. What is the clue for adriamycin thing here, apart from the hair loss? So few questions can come. how do you prevent alopecia nowadays? What are the device available to prevent? Can anyone see this slides? Just for clarity, students, just put in question. Can you see the picture?
Yes, sir. The picture is visualized, sir.
One structure. So, what are the complications? What are the feared effects of scalp cooling? So they usually say there is a Mets chances. There is a not leukemic deposit. There will be scalp Mets are possibility, but otherwise it is proven now that it's been used for a long time. It's not there. So next slide, I just go. So what is this clinical emergency, oncological emergency this patient is facing? Yes. So what are the most common cause for SVC in nowadays? Etiology. Usually nowadays we're biased with oncology, but most of the cases of SVC now are catheter related obstruction. Okay. Correct. Divya got it right. So which are the catheter related? How do you treat a catheter related thrombosis? Anyone? So catheter related. So usually what they do is usually patients thrombolysis can be done. The urokinase or even embolectomy can be done. So usually you have to refer a cardiologist, interventional cardiologist to the address the catheter related thrombus. Okay. So apart from malignant causes, it's the elderly patient. So lung cancer could be a cause. The treatment is systemic therapy. Usually now the role of radiotherapy has come down. So the usually questions goes in that way. So you will have usually you will have this case, and eventually it can lead to, if it is young patient, can lead to Hodgkin's lymphoma or primary B cell lymphoma or T cell lymphomas, or it can go to germ cell tumor, or it can go to the discussion we can go into. So there is a question in DNV exam last year. What are differential diagnosis for mediastinal tumors? Okay. So what is this condition? So one of the aspects which, sorry, can you see this slide? Can you see the picture, everyone? Okay. So what are the differential diagnosis of this Amarox figures apart from malignancy? What are the investigations you want to do in these patients? Staging investigations. What are the staging investigation can do? Very good. So one of the important tests, which I think students tend to forget, because especially if they're not worked on retinoblastomas, is examination under anesthesia. Okay. Apart from all the routine staging, we will do sometimes, if it is more than stage 2, we do even bone marrow, CSF, and everything. Especially what an important aspect, which is a staging investigation which can predict the prognosis. When you do a surgery, if what is the most worst prognosis sign? Yes, optic nerve involvement. So cut margin of optic nerve is positive, then the outcomes are poor. So do we have a guidelines for retinoblastoma? Indian guidelines? So who is the author of this guideline? Someone who has. So Santosh Honnawar is the guy who is works in a center for eyesight, who is authority in the retinoblastoma. Most of the data are coming from regional cancer centers where they see the high volume. So usually in early stages, we can do the vision saving. What are the goals of retinoblastoma treatment? Anyone? What are the goals? So usually goals is first to preserve vision, save life, if possible, extend the life. Okay. So you should know what are the vision saving surgery in the retinoblastoma. Dr. Krishna, you want to add something?
Yeah, so in retinoblastoma, you should just at least have a basic idea from group A to group E. So most of the children in India come with group E or group D, where there is orbital and extraorbital extension. So as Vinayak said, you have to definitely go for curative treatment. That is, if somebody asks what's your primary goal, to cure the child. What are your secondary goals? You have to save the globe and save the vision. So if you look at all the trials that has been going in retinoblastoma and the different regimens, earliest they try to avoid surgery. So you should never say what is your primary treatment, enucleation. Please don't tell that answer. You see, on exam, that's why that question that Vinayak asked, EUA is very important. Examination under anesthesia to see whether it is a retinoblastoma that can be treated with intraocular therapies. So you have thermal therapy, you have laser therapy, you have vitreal injections which are available now, intra-arterial chemotherapy with melphalan which is available, which is very much practiced in most of the regional centers. So vision saving, globe saving, secondary objectives are easily met. But once it becomes a group D or group E, which we commonly see, we have to give neoadjuvant chemotherapy and see if we can try to save. But if you cannot save it, you'll have to do complete orbital excenteration or enucleation followed by prosthetic eye. But as a medical oncologist, I would go on to ask extra questions. What else will you screen in the child? This child has come with unilateral amaurosis fugax. So what else will you do for the child? What else important history will you ask?
Yes. Two things. Apart from the retinoblastoma, you should do the pedigree analysis actually.
Very good. Yeah. Pedigree analysis is very important. You ask whether the parents, so you see the eyes of the parents. First, you screen the other eye of the child. If both eyes are involved, then it's likely to be a germline mutation. Single eye, older age child could be even sporadic, but that is very rare. And when you have both eyes involved, screen the parents. And if they are carrying the retinoblastoma gene, the parents also need to be kept under close surveillance for adult onset retinoblastoma and other secondary malignancies like osteosarcoma. And in the female, you have to do breast cancer screening. So these are the additional extended questions for this child that can be asked. Proceed, Vinayak.
So, what is the diagnosis? Hope everyone can see the screen. I don't know. I have question and answers with it.
Yeah, it's seen. Well, I hope everybody is able to see Vinayak's screen.
Yes, sir. The screen is
Yeah, because I have question answer in between, so I don't know whether they can see or not see. Okay. Osteosarcoma. So you should not say osteosarcoma. In spotter, we expect the site. The if the biopsy is the biopsy done in a right place? What are the precautions we have to take for patients in osteosarcoma to do a biopsy? Is the scar correct? What kind of scar should be there? Hope you can see the scar well. Can see the scar? Is it correct? Okay. What are the can anyone just put 1 or 2 points on how should do a biopsy? Who should do a biopsy? And signs. Usually, what is the treatment between patients who have neuromuscular bundle involvement? Is usually amputations. So if you have any of the so the main intent of osteosarcoma is preserve the function of the joint. So if you're not able to preserve the joint, you will usually do the amputation. So we want them to have a good quality of life because more than 60% of the patients are curable. So that is one. Second, in osteosarcoma, once it starts with what kind of histologies are there and what is the histological findings of the patients in each histology. Then what are the investigations we do? One is staging investigations. Second is the chemotherapy workup investigations. Then in each investigation, what are the choices? Like what is the gold standard for diagnosing necrosis? Then what is the survival expected in a patients who have good necrosis? Once you're done with that, then we'll have treatment options. How many drugs can be used for osteosarcoma? So can someone name drugs? Usually, in a center which they have resource restraint, they usually use cisplatinum and adriamycin and sometimes IFOS. But most of the MAP or patients, or sometimes in centers who can have access to MTX, they do a protocol based with MTX-based protocols. So what are the response rates, OS of each protocol? Is there any role for escalation of treatment, which is a study which has escalated the treatment and what were the outcomes? Then apart from that, surgical questions. When you do a surgery, limb prosthesis, how much time is taken for the preparation of the limb prosthesis? Second, what are the modular processes? Apart from processes question, there can be question where there is called a rotatoplasty. It is a kind of surgery where they able to save the ankle joint for functional movements. So that is one question. Then follow-up of each the follow-up of the osteosarcoma surveillance. Okay. So this Dr. Krishna, you want to add anything? So this can lead to anywhere. So usually we keep one spotter of head and neck cancers where you will only diagnose. Then the question goes for etiology. Then question goes for the tobacco cessation works. Then treatment options. What is the which are the tumors which head and neck tumors which have a predisposition for lymph node metastasis? Good one in nasopharyngeal carcinoma, tongue, tonsils, then oral cavity. So some of them are relatively don't spread. Which are the tumors? Which are the head and neck cancers tumors which don't have lymph node mets so much? Lip, correct. One more. Buccal mucosa sometimes, yes. And vocal cord, no. But supra and infra will have. Glottis, correct. So what are the HPV oncogenesis related? Are HPV related? There's any studies for de-escalation? So does cetuximab able to you can avoid cisplatinum using cetuximab? Which is a study which shows that cisplatinum is inferior to cetuximab is inferior to cisplatinum. These are the questions. Then apart from that, our Tata study will not stop there. You have to tell the proper dose of cisplatinum. What is the dose of cisplatinum given in the Tata study, TMH study? Yes. Okay. So that is one study which has shown dual double agents do work. Another study, another drug was used instead of using cisplatinum for patients who are not cisplatinum ineligible. Yes. What are the dose of docetaxel? Anyone? Can you use the full dose? Correct. So these are the questions can come for head and neck cancers, and then it will go for metastatic disease. I will not stress, but metastatic disease you should know first line, second line, and where you will not use immunotherapy and chemotherapy combination, and where you use immunotherapy and chemotherapy combinations. Is there a role for any immunotherapy in neoadjuvant? These are the questions which can come. So this is head and neck cancer. So slides are more, so I just go through. I'll ask one or two questions and then go ahead. Okay. So these are the spotters questions. I have covered all those instruments and devices. This I'll go fast, but drugs I'll give a way out for that. Okay. Anyone who can identify this? Yes. So PICC line questions identify where you use. You should know at least in your wards. So patients usually students tend to forget hematological malignancy, hematological disease. So you should be very sure. Tell all the indications, all the contraindications, complications of the process, and one thing will the examiner will ask is how do you advise a patient when this is inserted? So how frequently they should dress? What is the kind of dressing is required? And how to keep it flushed, and what is the principles of flushing, and how to handle the PICC line. And apart from this, for all catheter related infections, there can be questions. There will be how to send blood cultures. How many blood cultures has to be sent? And you have what is called differential cultures? Differential beep, it's called. So when you send a cultures, if both beeps, what is the significance? If one beeps after another, what should be the difference? Good. So there is a differential beeping of the cultures, which indicates the infection site maybe is PICC line. Apart from that, insertion site infection and fungal infections, and there are infections which can lead to remove the PICC line. Okay. Apart from this, the PICC line thrombus, how do you diagnose? How do they present? How do you diagnose? And what do you handle with it? Okay. These are the questions can come with PICC line.
Yeah, Vinayak, just so once again to all the postgraduates, you can take for assurance that 200% there will be a PICC line in the ward rounds because that's the easiest spotter to catch and keep. So whatever Vinayak has asked is very, very important. So what is CLABSI? Catheter line associated bloodstream infection. What is the definition of CLABSI? What is time to positivity? So when do you say that it is CLABSI? So along with that, the time to positivity also comes. That is about the beeping that he was trying to ask. So there are technical terminologies. In your center, what is your antibiotic policy for a patient coming with PICC line if infection is there? That is a very common question. Then what are the common signs and symptoms of a patient with PICC line where you suspect that PICC line infection is there? They expect you to tell rigor and hypotension. These two clinical findings you should know to say. After that, the next few questions will be on how can you, and whatever Vinayak said, this standard question. How do you dress the PICC line? How do you flush the PICC line? Are there PICC lines where you don't need a heparin flush? Like you have the valved catheters where you don't use heparin, you use only saline. So what are the types? How can you classify PICC lines? Valved and non-valved. So those questions will be there because the examiner will know whether you have really gone in and worked in the ward to look at all these things, or some PICC line team is doing the dressing and you just happily write the orders and come, which they don't encourage. And then the question will be about which are the conditions where you have to definitely remove the PICC line, which are the conditions where you can salvage the PICC line. So that is there in your books regarding the fungal infection and regarding all those other infections where you have to remove the PICC line. Please be very, very thorough with the PICC line. What are the solid tumor indications where PICC line is used? Usually we know hematological malignancies and epoch regimens and all that where we are routinely using. What are the solid tumor for PICC line? So these are the stock questions. Please write down the answers. Please revise it and go before you go for the exam. Go ahead, Vinayak.
Okay. The next is the what is this site? What is this catheter device? Anyone answered? Yes. So chemoport is another question. Can easily come either as device it can come, or either at a spotter it can come. The needle name, and what is the characteristic of this needle compared to other needle. You have to tell exact word that what kind of needle it is. And one more, non-coring and beveled. Okay. These two things are important. Apart from other questions such as like catheter related infection, like when this positivity comes. So only extra question which can come is flushing. How frequently you should do flushing? What should you do at the end of the infusion? If I give adriamycin, and then what should I do at the end of it? Second, hand washing hygienes we will ask. There is a bundle of care question in the catheter related infection that has been asked. And which are the indications? Which are the diseases we use chemoport? Which are the diseases we use? What is this one? Anyone? What is this? This catheter is called? Good.
What is the lumen size and how is it different from the routine Hickman catheter? What is the difference and where is it used? What is the indication where you have this double lumen tunneled catheter? So you should know about tunneled and non-tunneled catheter. Once again, when it comes to the central venous devices which are inserted, these you should know the classification, tunneled versus non-tunneled. And then in PICC line, one more, I mean, in the port, one more what Vinayak mentioned, you should know about that needle, the Huber needle. What is speciality of Huber needle? Why is it called non-coring needle? What is the meaning of non-coring? And how many pricks normally a port can take is around 2 lakh pricks. So, I mean, some of the standard questions. So now you please answer Vinayak's question. Where is this used? What is this catheter?
Some of you written bone marrow transplant. Yes, definitely we want. Some of the students who have not worked in hematology, so, I mean, this is too late in the day to tell. They don't know PICC line. They don't know the Hickman is used in the transplant. So they usually say chemoport and other things. We may mislead you on purpose to assess that you have done a work. So you have to be very sure that where is Hickman is used and where is chemoport used and where is PICC line is used. There has to be a very objectivity that not reflects your knowledge. It reflects whether you worked or not in your 3 years of practice. So apart from that, the lumens, how do you keep it active in the transplant? Which infusions will give in these lines, which solutions cannot be combined together? Those questions will come, especially if you don't answer initially, we'll ask that so that you should know how to give the drugs. This one question, I think that finishes the catheter. Anyone else can take this call? What is this device, this instrument? Yes. So now thing is in one other option other than ICD we can insert in the same space. Apart from ICD, what do you regularly yes, where you cannot use pigtail? Where you cannot use pigtail? What is the indication where you cannot use pigtail or you have to use ICD? Yes. Okay. So the thing is, you should know the indications and contraindications for ICD and other things. From that, few questions will come because some of the patients will carry it home. So we will ask you to explain to us as if you are explaining to a patient. How do you explain to handle the ICD? So you have to instruct the patient that you should watch out for the flow. The flow should be there. The water column should move. You should be below the level of the heart. And if anything is there comes, if the sometimes it can come out without any usually sutures are done well, but sometimes it comes out how to handle it. And when you remove, so what level you will remove? So what is the output should be that you can remove? How much? Yes, 50 ml continuously for at least 3 days. We will remove. Then fluoridosis, type of fluoridosic agent we use. Some of the people answer very randomly. So you should know very thoroughly the talc, bleomycin, and one more. And which is most effective. It's there in the Divita, which is the most effective one. Which is the most effective. So you have to read that because this will one of the questions will come. Okay. And response rates. And sometimes patients will require a VATs and followed by this thing. So when this can lead to sometimes questions about pleural fluid, IHC and everything, but those questions can go anywhere, but at least you have to know the functionality of this device. This one writes to. So who or what another device we can use for feeding? Good. So which one you should prefer? Is PEG preferred or rise to preferred? And how the questions will go from here, the swallowing and speech physiotherapy. So should patient, what are the complications if patient doesn't swallow or drink during the CTRT? Yes, there can be contractures. So these are questions will come in head and neck cancers. The feeding is very sentimental for a lot of oncologists, because we see the difficulty when the patient was very fit and over the course he lose the weight and becomes very sick. So the counseling for feeding is must. So we'll assess the student how much they have counseled a patient for feeding. So
And this is one area where we should know about the TPN, total parenteral nutrition, peripheral parenteral nutrition, the calorific intake needed per day. You should be able to say 30 to 35 kilocalorie per day. How much of gram of protein is needed? How do you do nutritional monitoring of your patient? So this can be there. Again, this can be there during the ward rounds. So like a spotter, you have a person with Riles tube. What are the types of enteral feeding and parenteral feeding? Classify, and then how much of caloric intake do you target for every patient per day? What Vinayak said is very important. Head and neck patient, as you plan the treatment, you have to say the examiner will keenly watch to see if you have focused on feeding part, because for the medical oncology, that's very important. Yeah, go ahead, Vinayak.
so these are the spotters. The device will be part of the patient apart from the clinical case. So few cases will be ward rounds, will be the adverse effect of the chemotherapy drug. Usually randomly who comes to our OPD will just brought. So no one has an idea, even expert will not have an idea. Can anyone identify? So we have another 15 minutes to go. So I'll wrap up a little faster. Questions: what kind of skin rash it is? It is a definite name is there, flagellate rash. Second, where it's increased, where is the bleomycin toxicity is seen more. So at least we expect raised renal function altered, use of concomitant oxygen during therapy. Few clinical implications. Sometimes patients get retroperitoneal lymph node dissection later date. So we expect that you take care of the oxygen related issues and the mechanism of bleomycin related toxicity. Non-bleomycin regimes, whom you prefer? At least favorite question for me is Yuvraj Singh's protocol. What was given? That protocol is very important. These are the questions will come most often for the students. So anyone can guess Yuvraj Singh's protocol? Which was the protocol? Anyone? Anyone who knows where he took the treatment? Who is the author of our BP seminal article? So these are questions when you get a really good answers, we'll go to that level. Otherwise, usually we'll not reach those questions. But those questions can go. So this is side effect of anyone. So chemotherapy induced skin and nail changes is one of the questions which will be always asked. This covers HFS, which I don't put the slides. That covers the discoloration of the nails, which is this currently adrenaline related. Sometimes you have TK related also. So we ask some questions like weekly paclitaxel causes what kind of side effect compared to 3 weekly. But you should be ready for at least 10 lines of sentence as soon as you see this diagram. Okay. These are the side effect. This is what? So this is the most valued scenario which we want a student to answer very thoroughly, very clearly. This is extravasation injury. Extravasation injury is iatrogenic, and at the time of injury, you can do a lot. But when patient comes like this, the options are very, very, very morbid, which involves plastic surgery, debridement, grafting. So we have to pick it up. One, what are the preventive measures which you should initiate before the such drug is given? So what are the two types of extravasation injuries? What is vesicants? What is irritant? And what is non-irritant? Which drugs will not cause any even extravasation doesn't cause it. So what are the difference? There's a difference between adrenaline extravasation and VCR thing. There is difference in the way we give hot compression or cold compression. That has to be very clear. Then what are the drugs we can offer to the patients, and what are the instructions you have to give to sister that she is able to do you keep the IV line open, suck out the infusions. So sometimes patients we need to apply Icar cream. So you have to be very clear with this thing. This extravasation injuries, if you've done a borderline case or you are on the borderline and you answer very without application of mind, because you go slow, you don't have to get it right in fast. You have to get it right in the thing. This is one thing which we were particular. So you have to be very thorough with extravasation injuries. So this finishes our spot rounds. Other investigations, images, anyone can take a guess? You have to be comfortable in getting the diagnosis right. What is the diagnosis? We're getting answers? No. Yes. So I'll not go into depth of it. Hodgkin's lymphoma. So this is where we assess your hematological knowledge. And this has to be, you have to get the image right. You have to live with this image, see every day, once, twice, and make sure this is in the perception. Once it's reached to Hodgkin's lymphomas, you have to get it right most of things, because there's no excuse for not knowing Hodgkin's lymphoma thoroughly. The risk factors, the pathological features, the treatment aspects, PET scan, interim PET, implication of interim PET, escalation of a treatment, indication for transplant, complications of each drug of chemotherapy, how do you prevent the sperm banking, the toxicity, all these things has to be covered very thoroughly and very systematically. You can expect all the questions coming, because sometimes we give a choice for you, or sometimes we don't give choice, but usually pathological images you'll not have any choice. Okay, and they'll not be repeated to each other candidate. So what your fellow colleague will get, you will definitely not get. So you will be ready for one more. Okay, so this is, what is it? Can you see? Should answer fast actually. He's asking question to me only. Okay. So this one you have to get it very right. What is it? So how do you say that diagnosis? How do you say it's plasma cell or myeloma? Okay. Sorry. This is it. Okay. This you have to get it very right. Okay. Questions will go into the regimes and other things, but most of questions you can answer well. Okay. Clear? This one. So for short of time, I'm just rushing through slides. You're able to see the image, right? Dr. Krishna, you can take. So APML, CML. Okay, what is this one then? If this, that was the APML, some of them you said. What is this one?
Is this a peripheral smear or a bone marrow smear? Can somebody tell whether it's a peripheral smear or a bone marrow smear?
This one is what, and this one is what?
What are the cells seen in the background? From that you can say what is that smear.
I think some of us have covered the slides also, I feel, but what is this one? So when it is done this one, so these are the slides: AML, ALL, APML, myeloma, CLL. These are the slides we usually keep. So what are these kind of graphs called? And what is the underlying principle? flow, I agree with it. But what are the grams are called? Yes, scattergrams. Okay. There are forward scatter, side scatter. So you have to understand, we'll ask which is positive. In this patient, what is positive? Is HRR DRS positive or CD7 is positive? Anyone? What are these four quadrants? What are this quadrant positivity indicates? So these are questions will come to students. We'll give we will give the scattergrams because in our practice, scattergrams are given by few labs. Some of the very good hematologists will usually ask for the scattergrams. Okay. So for sake of time, I'm just rushing through it. But this graph, you have to be very understand. You don't need to tell the what is the principle of flow cytometry. What is that flow cytometry technique is called? How do you make sure that you get a right scatter here? Anyone? Okay, optics is correct, but not fluid optic. I mean, it can be a little better. Gating is fine, but that is only the way. So there is a mechanism where we will use the beads to so this one, this is the final report, same patient's final report. So you can see the expression of HLI-DR 34. You can see that stains. So just see one or two reports of your patients which you have seen in your thing and try to understand the mechanisms. What is this one? What is on the left side? What is on the left side? This one. No. Don't give diagnosis. Tell me what is it? What is this investigation called? Karyotype. Conventional karyotype. So usually people don't get it right. So you should have conventional karyotype. How it is done, type of conventional karyotyping, and what is the significance. Okay. What is this side one? Other right side one? Fish. What kind of probe is used? What kind of probes you know? So the questions will not stop at CML. We would go for all fish. We would go for where are all the fish tests are done. So how do it looks? Which are the here? Which is the I think the arrow is there, but anyway, which are the how it looks? This is the which is the red is what? VCR or ABL? Green is what? So these are questions which can come for your this test. This is usually correct. All okay, it's good, but yeah, red is BCR and green is ABL. So can you see this RT-PCR? So steps, I think last year, I think PCR was a question, main question. Half of them wrote reasonable, few of them wrote exceptionally well, and some of them didn't get the RT-PCR correctly. So the technology of PCR, pre-PCR workup, then DNA extraction, steps of PCR, you have to be thorough. And coming to the CML, we want to know the difference between qualitative RT-PCR and quantitative PCR. And we want to know the TFR, how do you monitor? What is the sequence of TFR? What is TFR? What is TFR? What is TFR in CML? Yes. Which is the study from which this data has come from? Which is the study? First study. Yes. Stop stream study. Correct. So, and for each TK, it's a different depth of response is there. So we're going to ask you the molecular emissions, like when you're going to achieve your MMR, when you're going to achieve complete MMR 4-5. Those questions will come apart from these questions usually. Then what is IS scoring or how it is different? How many of you know what is IS? Here IS is there. What is it? How it is derived? To what it is compared? And this we'll ask even in HER2, which I have not covered, but in HER2 also we ask. Okay. What is this test? Is it MSI high? What is BAT? What are the how many of those 13 markers? Can anyone name? So that flow chart, which usually accompanies this report, should be seen. So this is one test we would ask. And apart from this, whenever there's two IHC, if you have only two positivity, when you will do MLL and when you do BRAF mutation, those questions will come. BRCA. So this BRCA, both are positive, but there are cases only one positive will be there. And how do you do the NGS? Steps of NGS, and what is VAS, and how do you handle BRCA positive patients for patient herself, for her disease, breast cancer, for her risk of ovarian cancer, for the siblings. These are questions will come. So I think we are reaching the time, I feel. Correct? So
Vinayak, just before you wind up, just 2-3 points. CML. What is the first test of choice for confirming CML? Please don't forget it is only qualitative PCR. Many of the students are saying quantitative PCR for diagnosis. We need only hotspot mutations to be screened. Qualitative PCR is enough for diagnosis of CML. We don't need NGS and we don't need a quantitative PCR for diagnosis of CML. So please don't make that mistake. And what is ISS? You have to be thorough. What are the various loci in BCR ABL? The 190, 210, 230, you have to know. The various cryptic loci which can be missed when you do other forms of PCR. And one more question that you have to generally know is what's the difference in PCR versus hotspot mutations versus comprehensive genomic profiling. So what is this NGS, limited hotspot NGS? What is this comprehensive genomic profile? What is whole exome sequencing? Just some basic, single liners to see what is the difference. PCR is nothing but amplifying the gene and saying whether it is there or not. Whereas when you pull out the hotspot genes and then sequence it end to end, that is called sequencing. So that you can do on limited panel, you can do an extended panel. So that is about NGS. In today's world, without that, you cannot go. So there will be an NGS report. One more thing which I wanted to say is, please know what's the difference. What is a co-mutation? What is a compound mutation? What is a passenger mutation? Each of it is different. Many times you find EGFR mutation, you find a L858R, and then you find a P53 that is also present along with it. Is it a co-mutation or is it a compound mutation? That you should know how to differentiate the two. So I'm not going to go and tell you each definition. I'm just dropping the questions because we are nearing the time. Time has just reached 9 o'clock, as Vinayak said. So for the basic NGS report reading, what is variant allele frequency? And how do you determine whether you may have four? Vinayak put up one thing where there are 4 different mutations in EGFR. So which one is the driver mutation? How do you determine which you have to target first? These kind of things will be based on the VAF. Yeah, this one. So there are 4 mutations in this. So which one are you going to target? How do you find the difference? And in T790, T790M, you have a CYS797S and then you have a trans. So which one the chemo will work and which one you can still try osimertinib. So these are few things, standard stock questions. Please go and read because in CA lung and in EGFR mutation, if you go and stand there and you will cut a sorry figure. If you have a PDL1 positivity and you have a target positivity like EGFR or ALK, which one will you target first? Are you going to do the PDL1 therapy first or target therapy first? It's always target therapy first. Please go and read about that and then keep some data. And last but not the least, please be ready with all the Indian data. There are tons of papers that have come out of TMH, a lot of papers that have been published by Kidwai and even some by Adayar and teams. So respective to your particular area of interest, if you are not able to quote some Indian studies which are very much spoken in literature, sometimes it creates a bad impression because you go on talking about NCCN guidelines. Saying that last but not the least, please don't go and say in NCCN guidelines they are saying this. Some examiners don't like to hear that word. Use the NCCN to form your own protocol. See what you're doing in your center. Please go and present that to the examiner when you're presenting the case. So that's very, very important. And I think that's all I have from my end. Vinayak, any closing remarks, and then we'll hand over to the organizers.
I have to rush through a few slides. I'll just go through it.
Yeah. Finish it off. Finish it off. You have nice slides. I know what all you have after this. Please finish it off.
So this is multiple myeloma. So the questions can come. So moth-eaten. So description. So you have to be ready with the what is view, what are you looking, then etiology if possible. So be clear. You see a fracture. You see this osteopenia. There is seen moth-eaten appearance. There is mandible involved. These are things which we want to in a multiple myeloma. After that, questions will go to myeloma. I'm not going there. This slide has to be understood well. It's not a pediatric. You see the fusion of the thing. So you get right then go further. And this is the what is this slide? The osteosarcoma slide. You have to get it. The periosteal elevation. You see the relative osteopenia. All these features of the bone tumor should be correct. Sometimes you may, instead of osteosarcoma, I may cause Ewing sarcoma, depending upon our choice. But usually this one will be there. This is what is this? Anyone? DEXA scan. So the questions will gonna come on DEXA scan. So especially AI aromatase inhibitor, we're gonna do it screen. So these questions will come. Apart from this, nutrition also DEXA scan will come, but usually it is more for the AI usage. So whom will give osteopenic dose, zoltanic acid, and whom will give it for the monthly dose. The questions will come. PET scan, principles of PET scan, and PSMA PET scan. What kind of dye is used? How it looks? The scoring system, the PERSIST scoring system. Then the full form expansion of SUV, and how Dulux scoring for Hodgkin's lymphomas. These are questions can come for PET scan if they keep the image. Then instruments. So instruments, again, it's same thing. What is this needle called? So where you do the aspiration only, we'll not do a biopsy. Most of our practice nowadays, at least in my practice, is more of a biopsy. But there are, no, this is not Jamshedji, it's a Salil. So Jamshedji is this one. Okay. This is for aspiration needle. This is the bone marrow biopsy and aspiration needle. This have to be correct. Even if you don't get the name right, we at least want what purpose it does. It only does the aspiration. It's done where and what precautions will take. Why that this bevel is, this holder is there. This has to be very clear. Then this is the bone marrow needle. You want to ask the steps, especially how do you crack the bone to take the sample. There are questions which are going to come specific for the bone marrow needle aspirations. This is what? Anyone? What is this instrument and what is it used for? Yes, it is the gun biopsy or true cut biopsy. Whenever we want a patient for the tissue diagnosis, some of the centers in medical oncology does it. So you should know it. This is, what is it? Anyone? So what are the indications, contraindications? We want to know the contraindications. We want to know the complications, guarded LP, then cytology, CIN 1, 2, 3, then CNS directed therapies. Then sometimes if you really do well, some of the intrathecal other than standard intrathecal bottle you can give. And what is the difference between methotrexate which is used for IT and what is used for normal? This is a question. What is it doesn't contain? That's a question we can we ask. This is one thing you remember. Instruments, drugs, you get a choice. So at least 3 instruments and 5 or 6 drugs, you have to be thorough. If as soon as you pick it up, you start rattling it. That's very important. You get a choice. for 50% of the students, you get a choice. So this is again pick line. I'm not going to stress. This is again chemo port. It can come as a, you should be able to pick it up. Okay. Drugs. So everyone will get a cytotoxic, a monoclonal antibody, TKI, supportive care. These are the questions. So for each drug, you should tell a class of drug, mechanism of action, if possible, resistance, indication with the dose. You should tell each indication with the dose, side effects, unique side effect, class side effects, administration issues, some of the drugs, what form it comes. Especially, we want to know whether you have mixed the drug. Okay. Some old examiner will ask you what color, what is the formulations. If you don't know, say don't know. Don't guess out of the chance. So bendamustine. So each drug you have to tell all those headings, cytotoxics. Okay. So you will get one cytotoxic, one small molecule, plus or minus hormone therapy, maps. So you will be ready with the answers. Okay. The
And codon set. And codon set is very important. The inline filter. What is the inline filter? What is it made of? What is the purpose of a codon set while giving chemotherapy? Which are the drugs where you give codon set? Use codon set. Please learn codon set. That's one of the things that will be kept in the instrument bag.
So I think drug classes have been done very nicely by our previous speakers. You go and do the diligence. I'll not talk about it, but that day, if you given a choice, you pick this one of your drugs and be ready with rattling the answers. So last one, but least one in even DNB and some of the exams are there. Your thesis would have forgotten conveniently by the time you have gone to exam. Read your thesis, at least abstract. You should tell it out without any second look. Your all results to be thorough. Logbooks is a new trend started. Now logbooks have been seen. Do a good job. Ideally, if it's any early students are there, write every day. That's it. So the few slides are there which we have done previously, and even the YMO is there. Use in a way that it's useful for you. You can find your merits. But all the best for exams from my side. This is my last slide. Thank you.
Excellent, Vinayak. Excellent. The usual, we can see the teacher in you. Any other doubts to ask Dr. Vinayak from our postgraduates? Anything else? On Sunday, we have a class on hematology. Some slides and few flow cytometry patterns will be shown.
That's
how
why
each drug is administered. How each drug is administered, as Vinayak told, very important. Please know the drug templates of cisplatin, drug templates. You all will be used to printed templates in private hospitals. So you want to know what to tell the examiner, how a pre-medication is given. Please go and read. 60 minutes infusion. I have seen some PGs who said we will give 900 milligram of cyclophosphamide in 4-hour infusion. Please, because you are not sure, because it's all there in the template. You have not read that it is a 90 minutes to 120 minutes. You have not read. In fact, cyclophosphamide, you can even give a shorter infusion. You can even give bolus in cardiac failure patients. So basically, you should know how each drug is given. That has been extensively covered. That's why Vinayak has not gone into it. And other things, whatever, we have only touched the tip of the iceberg. I think you just keep this as a pattern. Try to rehearse yourself, ask yourself questions, ask your friends questions, prepare and go. That's the only clue to go for exam. Thank you, Vinayak. And Nihanti and Karan, can we close?
Yes, sir.
Is
We
it
can
fine?
close, sir. Thank you so much, Krishna sir, Vinayak sir. This was a very vast discussion for all the students, and it's been really helpful for everyone. And I also thank Amrita E-Gurukul for taking an initiative. So thanks a lot, sir. Again, I hope all the students are benefited with this. And with this, we are ending the session also.
Thank you.
Sir. Thank you.
Good morning to all the postgraduates who are going for exams this coming week. So we were forced to do a very urgent session because I think from on Monday, the first sessions of practicals are starting. We have a lot of postgraduates from TMH, is what I came to know. So we advanced the session a bit to accommodate because there are 2 major programs this weekend. So we are stuck with as a faculty in those programs. So the basic thing will be, we are going to give you a glimpse of few things which are commonly kept and just what will be the kind of questions that are asked and how it should serve. You should extrapolate this to anything and everything else that may be kept there. But just we'll give you a glimpse of few things so that you get an idea of what is being done during the routine examination. So this is especially for the DRNB students, because DRNB gives a very fixed format of conducting the exam and we don't deviate the patterns too much. Okay, so you'll have 2 sessions. In the clinics, you will have ward rounds, and that is something like a spotter where you don't literally talk to the patient, sometimes not even touch the patient. It will have certain clear clinical findings. And there will be a semi-long, which you are aware, a brief history with the examination and the presentation, 4 cases. So 4 spotters, 4 semi-long cases. And then the afternoon session, you have the Viva OC. So I will be starting with the table session right now, and then Vinayak will join soon and discuss a little bit about the spotters, which will come during the semi-long. I mean, during the morning session. Semi-long, I think we've done a lot of case presentations in the last almost 2-3 months and like a crash course over the last 6 weeks, which kind of has covered most of the important areas that will be covered in the semi-long case. Okay. So first slide, can we just move on? Yeah. So first, let's start with radiology. Just a couple of sample. Okay, I have not put everything up there. Some samples. So first, radiology. Yeah. So this, maybe we can keep the chat box open so that if you want to chat, you can chat, because the voice may become a little, too many people talking at the same time. So this may be a very typical X-ray which is kept for most of the people, most of the postgraduates who are going for their exam. So I think it's a no-brainer to say that this patient has, it's a chest X-ray. And always remember that you have to start reading the X-ray. So when you say this is a chest X-ray, this is a PA view, and then you say that I see multiple rounded opacities. So that is the way you describe. Sometimes the examiner, if you're short of time, they'll say, okay, tell me the diagnosis. It's okay. If that's the thing, then you can directly go. So this is an X-ray which shows multiple bilateral lung metastasis, right? Very good. So you have to have what is going to be the differential diagnosis. You should keep multiple things in mind. First thing you observe is, don't get carried away by the lung shadows. Please look at the skeletal cage. You may have a large lytic lesion, although in this X-ray it is not very clearly seen, but you have to, sometimes you can get up from your position, you can go closer, you can see the X-ray on the X-ray lobby and see there may be a rib erosion. There may be a vertebral erosion, which is slightly better seen. This is a PA view, so vertebra is not seen. So those kind of subtle findings, the examiner may be wanting to see if you're in the ocean of findings, whether you have missed. So just remember that that is something that is very important, which it will be good if you're able to pick those things up. So if it's a young lady, I think Pradnya has already put it on the chat box. Think of always GTN. So what's the first thing you will do is ask for history of LMP. What's the first test you will do? You will do a urine pregnancy test. You are not expected to tell flamboyant things. And a serum beta HCG, if it is available in your hospital in the casualty. So at least a simple thing, urine pregnancy test, and ask for history of LMP. If it's a 25-year-old male, what is the first thing you want to examine? I would like to examine the genitalia. I will look for testis. And then I will ask for beta HCG, AFP, LDH in the casualty before branding him metastatic disease and sending home. If it's a 60-year-old lady coming with this kind of findings, or a 60-year-old man coming with these kind of findings, then obviously you are looking at multiple metastasis. So you have to look at various metastatic according to epidemiology in India. So if there is a dominant lung nodule and then you have multiple metastasis, you can think of CA lung, which is one of the most common malignancy in the world in males and females put together. And all the other come after that. You have well clear rounded shadows. You can think of sarcoma, you can think of stomach. So there you have to know the epidemiology. Once again, I'm telling all of you, your differentials go according to the epidemiology of the disease in your particular center or in India at least. So please know the top 5 cancers in males and top 5 cancers in females in India with a rough incidence per 10 power 5. So please know that when you're going for your exams. Next slide, please. So this will be the next common X-ray, which almost always is there. So this is a mediastinal widening. So This is a 14-year-old boy is there in the casualty, and this is the X-ray. What is the first thing you want to do in this 14-year-old boy? What's the first test? So obviously, a medial channel widening in a 14-year-old boy, you are going to think of TALL. It's a lymphoblastic leukemia or a lymphoblastic lymphoma. Good, Dr. Tulsi. So you got it. So you have to do a CBC and peripheral smear. I'm going to look at leukocytosis. I'm going to look at thrombocytopenia, even before anything else. And what's the next immediate test you do if you find leukocytosis? If they have asked, the next is immediately you will try to do a TLP, the tumor lysis profile. You want to rule out tumor lysis syndrome in this child, and because that needs immediate correction. So some of the postgraduates, they get a little carried away. So they say that there is a medial channel widening, and then how do you diagnose? We'll start working up for, the true cut biopsy and all that. So make it simple. Most of the senior examiners just expect a peripheral smear and tumor lysis parameters that has to be checked in the casualty. So obviously from this point, they may go into discussion a little bit about how do you classify tumor lysis, how do you classify, the clinical, the Bishop-Cairo criteria. Few things may be asked. So always tumor lysis is a very favorite question for most of the examiners. Yeah, regarding PMBCL, which was dropped here, yes. So now you go to the middle age. I mean, PMBCL in a adolescent kid. So whenever you are looking at somewhere 8 years, 10 years, 14 years, you bring lymphoblastic first. Second decade to third decade onwards, you can keep PMBCL, especially it's a female, keep PMBCL in the mind. And then what else do you keep in middle-aged males? What would you like to keep in mind? What addition to this? It's a non-semitomatous germ cell tumor in addition to lymphoma. And then slowly, by the end of the third decade and early fourth decade, that is in the 30s, you have to keep also lymphoma in, you have to keep thymic tumors in mind. And then finally, if it's a smoker and if you have elderly people, you can even, it's a mediastinal mass. It may be a primary centrally located mediastinal mass with multiple lymph nodes in the mediastinum. You can think of a smoker, especially if it can be NSCLC. So the X-ray kept there is a pediatric X-ray like that. But the discussion will go across the age group. So keep multiple differentials ready in your mind. And as the examiner is asking, you can tell. So as far as when he says it's a young boy with this, your answer is always ALL. The last question was just a brownie point. If you have the patient with Cushingoid features, what would be the differential diagnosis? You can think of a paraneoplastic Cushingoid syndrome because of ACTH, paraneoplastic ACTH secretion from a CA lung. It can be SCLC. The other thing is, it can even be a neuroendocrine tumor that is coming out of the mediastinum, but this is a more centrally located, and you are not looking at thymus. Thymus, it will be a little more superior and superior mediastinal tumor. Then you can think of neuroendocrine tumors of the mediastinum, which can cause thymus, which can cause Cushingoid secretions. Next. So this is, what is this? Anybody wants to drop in what test is this? Bone scan. Very good. So what is the tracer that is used in the bone scan? Technetium, right? So what are these two sets of images? Are they 4 patients or are they the same patient or are they 2 patients? So the one on the left, many people are unable to clearly say this. The one on the left is the early image and the one on the right is the delayed phase. So why do you have 2 phases? In the early, usually there is a very rapid uptake in the vertebral, the central skeleton, that is the axial skeletal. And in the delayed, you will have the appendicular skeleton, which will take up the bone scan. With the advent of PET scan, what happens? I think we are hardly ever seeing bone scans in our clinical practice right now. So the PGs may not be exposed to it. But the examiners who are going to come to you usually will be senior people, and we have been trained in the bone scan era. So we would like to put up at least 1 or 2 classical bone scan. So so here is the uptake more or uptake less? Is there a very brisk uptake or very mild uptake? The delayed images. What happens when the technetium is taken up? The technetium gets excreted through the kidney. So in the delayed images, usually as the technetium gets out of the skeletal system, you will start seeing the renal shadows and some soft tissue shadows, and everything goes up. So as the appendicular skeleton takes up, you will start seeing the kidney. The initial phases will not see, you will not see the kidney immediately. Then you will see the kidney, and the whole thing will start. The tracer excretion will start occurring. But here, what are you seeing? There is a very, very brisk uptake, and the kidney shadows are not even seen, telling that all the technetium that you have given has gone into the skeletal system and it's not getting, you are correct. So it is a super scan. Okay, so super scan. So two malignancies that can cause super scan. In other words, what are two malignancies which has a very brisk uptake? Next slide. Excellent. Prostate. You can have hormone positive breast cancer. You should be specific. You should say hormone positive breast cancer and lung. Okay, that these are diseases where you have aggressive, bone metastasis, osteoblastic metastasis, which takes all the technetium. So these are examples of the super scan. One or two benign conditions like hyperparathyroidism, renal osteodystrophy, and extensive platelet disease also can cause super scan. So super scan is something which is favorite for many of the examiners. Next, please. This is another condition. So please go back and read what I have written. This is a prostate patient, similar to the previous patient. Started on ARB, androgen receptor blockers after orchidectomy. So PSA baseline is 2.6. After 2 months of treatment, PSA is dropping to 0.5. 4 months, it is dropping to 0.3. Okay. But surprisingly, as the PSA is dropping, patients become asymptomatic, pain has gone. But the bone scan, what is it showing? It is showing increased uptake. After initiation of treatment, there is an increased uptake in the bone scan, but the patient is improving clinically and biochemically. What is this condition called? Anybody wants to drop in the chat? Excellent. So it's called a flare phenomenon. So patients who are extremely sensitive to therapies, especially hormone therapy, this happens in, next slide. So this is usually seen in patients with CA breast, hormone positive, who are initiated. So these are the patients, either you will have super scan to start with, or if they have here and there some metastasis, it may flare up as you start treatment. So it's called a tumor flare. It occurs up. Next slide. So these are the points. How do you differentiate between true progression and tumor flare? You should know to say a few things. So sensitive malignancies. Myeloma is a hematological malignancy where you can find tumor flare. Breast and prostate cancer. Normally, you don't do bone scan in myeloma because they are all osteolytic. You have more of osteoclastic reaction. But at the same time, suppose if there is a soft tissue, and when you have started treatment, it responds so well that there can be an initial flare followed by a drop in the activity. So that is what, so these are usually 6 to 12 weeks is the time. So usually around 3 months, you will be able to, till 3 months, you'll be able to see the tumor flare. So your other clinical parameters and alkaline phosphatase levels, tumor marker levels will help you to differentiate tumor flare and progression of disease. Next, please. So these are 2 scans done on the same patient back to back. I have referred the patient to the nuclear department. The nuclear physician does the first scan and then goes back to the case sheet, and then he does the second scan because the first scan didn't find any uptake, but the CT shows a nice growth sitting in the stomach. What do you think is happening? 10 seconds. I want somebody to drop. What do you think is happening? PET scan done here, and scan B is another type of tracer. Okay, Tulasi, you are guessing that it is NET and then they have done a DOTA. Acceptable. But it's a CA stomach and it's a carcinoma in the stomach. Very good. Very good. Good, Udiptya. So it is actually a CA stomach. Next slide. Next slide. Yeah. It's a FAPI PET. So this is coming up in a big way. It does not go by the glucose activity, but it goes based, the target is basically the fibroblastic reaction or the inflammatory fibrosis that occurs in the tumor, which is very common in epithelial tumors, especially patients with the, signet ring tumor, signet ring adenocarcinomas. They are very poor in taking FDG. Therefore, there can be a false negative in the FDG PET. Second, if the patient has not been fasting, you cannot do FDG PET. And response assessment sometimes becomes inadequate in FDG PET. So now FAPI PET is coming a big way. It is much faster to do because within about 20 minutes of injecting of FAPI, you will be able to do the scan, whereas you have to wait at least 1 hour for the sequential scan to be taken in FDG PET. So now FAPI is becoming more famous, especially in epithelial tumors. Next, please. Now we will come to what Dr. Tulsi was trying to say. This is a gallium dotatate scan. Okay, so these are two things that can somebody identify where is the primary? 10 seconds. Timer. Yes, Arvind. Duodenum, liver, pancreas, liver, duodenum. Okay, you are all somewhere around that area. So it's little bit below the duodenum. So it's likely, which is the most common site for, if you're saying that I want to suspect neuroendocrine, where do you think most of the neuroendocrine tumors come from in the GI system? PNET is not neuroendocrine. PNET is like Ewing sarcoma. So yeah, so it's usually the periampullary area, and it is especially in the pancreas. Okay. So here you can see the second arrow in the second picture is so clear. It is from the pancreas, and then you find two brilliant enhancing nodules in the liver. So this is likely to be dotatate showing such a strong gallium uptake is likely to be a pancreatic primary with two metastatic nodules on both lobes of liver. And what you have to remember, one clinical point, this is for practice also. If you have a patient who's coming with extensive metastasis, extensive bone metastasis, extensive liver metastasis, but the patient seems to be walking into your OP without any major symptoms and cold looking, and has been referred to you as a metastatic pancreas or a metastatic stomach, always keep in mind neuroendocrine tumors, because neuroendocrine tumors, they can be metastatic for years without causing any symptoms. So this is just a practice point. Can somebody tell me what is net PET score? What is the least score and what is the maximum score? What is the least score and what is the maximum score? And what is it? One, yes, you are correct, Dr. Tulsi. It is the one which tells you whether we can. So you know that Dr. Hari usually gives you a net PET. Very good. So Dr. Hemlata, if it is 1 or 2, what is your inference? And if it is 5, what is your inference? Which is the more differentiated one? Is 1 more differentiated or 5 more differentiated? Go to the next one. So this is the net PET score. So if they in the dotatate scan, based on this, if it is 1 or 2, they are reasonably well differentiated. They are low grade. They have an excellent prognosis. They will respond well to your the therapy, with the somatostatin receptor analogs. Whereas as it goes into 3, it becomes intermediate. So earlier, we were taught as carcinoid, atypical carcinoid, and neuroendocrine carcinoma, large and small. This was the kind of classification we learned around in 2007, 2008 about neuroendocrine tumors. But now it is clear that it is NET is one entity. You have well differentiated, and in that you have a grade 1, grade 2, grade 3. Then you have a poorly differentiated, and then you have a neuroendocrine carcinoma. So 5 will respond only to chemotherapy, either etoposide cisplatin, or sometimes you may have to go to temozolomide with all the other captum like regimens for 4 and 5, whereas you can go with next one. So you would have seen lot of scans, lot of talking about doto-knock, doto-tate, doto-talk. So these are some differences between the various types of nuclear imaging. And, the doto-tate is kind of very strong for SSTR type 2. You have a 2, 3, and 5, which is usually expressed in the neuroendocrine tumors. and 2 is the strongest ability. So to have the best bet, what happens is they take dototate is being used in many of the centers. Some centers use dotonol because they have a better uptake, little more expensive. They have a better uptake, and you will be able to give a clear net pet score with dotonol. So if they ask you the difference in the Viva based on the scan, what is a dotonog, dototate, and dototoc, just it is regarding the specificity to the various types of receptors. Okay. And obviously, if it's very, very small, please remember one more practice point in neuroendocrine tumor, the primary may never be seen. It may be a pinhead size primary, but with large liver metastasis and bone metastasis. That is why I said, when you have a cold looking patient walking into your OPD without clear findings, keep neuroendocrine tumor in mind. Next. 10 seconds. 2-year-old child coming with the abdomen pain and abdomen mass. Very good. Very good. So what are the arrows pointing to? Very good. So it is claw sign. So can somebody tell what is claw sign? I think we had a pediatric tumor discussion yesterday or day before yesterday, I think. Very good. So it's claw sign. Claw sign is very important. It is a compression of the renal parenchyma. So the vascularity, everything gets pushed. There is concentration of the vessels gets played around, and all the dye goes around to the compressed renal parenchyma, and the tumor is intrarenal. So what happens is the contrast is so beautifully, around the tumor, the compressed renal vessels, renal parenchyma shows sharp indentations along the tumor that gives you the picture like a paw, a cat paw with its claws, So that is called as claw sign. This is very important for differentiating intrarenal tumors from extrarenal tumors involving the kidney. Extrarenal, you will not find the claw sign. It is not specific for Wilms tumor. It is mainly for Wilms tumor. But anything like mesogastric nephroma or even an RCC, this claw sign will help to differentiate intrarenal from extrarenal tumors. So this is the Wilms tumor, classical Wilms tumor. Next. So please keep all these things in mind. We will go to the next immediate differential diagnosis. Okay, next. They may ask you about the Wilms tumor triad. They may also ask about those things from this CT. Be ready with that. I'm not going to go into all that. Here's Dr. Tulasi. So this is a neuroblastoma. So earlier you saw a Wilms tumor. Now you are seeing a neuroblastoma. So what is the difference? 10 seconds. You can write in neuroblastoma side, what are the things that are present in neuroblastoma and not in Wilms tumor that helps you in differentiating. This is a stock question for all examiners. Excellent. I think all of you have got it. Ram, you've also got it. So when you have a tumor that is crossing the midline, it is present on one side unilaterally, but has extensive nodal metastasis. Next slide, please. See, first see the age. The younger the age, the most common tumor in infants is neuroblastoma. The median age is about 1 to 1.5 years, whereas in Wilms tumor, the median age is about 3 years. And up to 5 years, you can find 5 to 6 years, you may be able to get children with Wilms tumor, usually 5 years, upper limit. In neuroblastoma, finding heterogeneity, necrosis, chunks of calcification, extensive lymph nodal metastasis, crossing the midline, seeking the bone. Usually Wilms tumor rarely seeks the bone. So seeking the bone. So what they will do is they will keep a picture of this abdomen mass and then keep an X-ray nearby with multiple lytic lesions. Okay. So that kind of a geographic moth-eaten lytic lesions with this kind, and when they say it's a 1-year-old child, I think you have straight away a neuroblastoma. So why I am bringing these points inside is many times pediatric cases, they don't allow examination. So the examiner doesn't know how good you are in pediatric side. So all the discussion in pediatric oncology will come during the afternoon sessions, starting from Wilms tumor to neuroblastoma to an X-ray showing osteosarcoma, Ewing sarcoma. Even osteo, they are all middle-aged boys. They may, cooperate. But these small kids will never cooperate. So the discussion will come only in the afternoon section.